We're good? Okay. Well, hello and welcome. I'm Dan Jones, and as chair of the Department of Surgery, I want to welcome everybody to our first hybrid surgery grand rounds in quite a while. I'd like to take a moment to thank all of you who've made a very warm introduction for me for the last couple of months. It's been a pleasure for me to get to know many of you, the terrific work you're doing, the teaching you're doing, the extraordinary care you're providing. I also want to take a minute to thank James Guerrera, who has been interim chair for the last 2 years, and his leadership. Now, the real pleasure for today is to introduce Executive Dean Maria Soto-Greene as our distinguished speaker for today. Dean Greene does everything. I mean, she runs the med school. She's in charge of undergraduate medical education, accreditation, faculty development, and diversity. She's held major leadership roles in the AAMC. She's, throughout her career, has advanced diversity and inclusion throughout academic medicine. And getting to know her, she's a phenomenal person, mentor, and role model for all of us. And so, Dean Greene, it's a pleasure to have you kick off our hybrid session for today.
So, good morning. Good morning, and it is interesting because right now, at least I don't see my own image, which is a good thing, but welcome to the colleagues who are remote and, and it's good to see Dr. Kunek in terms of really she worked to orchestrate this 5 hospital unity, and I think that's really important, so I do appreciate my colleagues that are here. I know that you won't be able to talk to us yet, and hopefully you will towards the end, but I did have an activity which we don't have on the screen, and I wanted to kick it off, but I'm hoping that, and you don't have to disclose how many of you, at least in the audience here, because we won't be able to hear those remote, but you can please use the chat function, did an IAT. Uh-oh, all righty, that's okay. But I encourage, for those of you who didn't do it, it's really, really eye-opening, right? That's the implicit association test. Is there anyone in the room who did an IAT that would like to share their reflections on it? And I don't know if we have the portable mic. I know it was here a minute ago. She showed it to me. And I don't know where it is. Do you see it, Dan? The portable mic? I know she had it a minute ago. Because I know otherwise that the remote individuals won't be able to hear us. Yeah, I think we're going to need to, because she showed me the mic earlier, but I don't know where it is.
Okay, so I did the gender science IAT implicit association test, and my responses suggested a slight automatic association for male with science and females with liberal arts. And obviously between my undergrad and my current work, that was a little frustrating to hear. Do you want me to read the percentage? I don't know what else.
No, that's okay.
Okay.
I think that's important. Maybe we could, do we share the mic so that, I think I see Anastasia raised her hand, so she may want to share. And what we just heard, right, from a colleague, that's not uncommon, right? You could belong to a group, right? But because of how our experiences have been shaped, right, since childhood, our personal and professional experiences, we unknowingly still harbor, right, those cues. So when we did this before with women, and we focused on, because there are 2 types, you could do gender or gender science, it was not uncommon that women had a preference, thinking that the more appropriate associated role is a male role. And you'll see when we go over the data. So just want to bring these out to your level of consciousness and discussion. So Dr. Kunek.
Hey, it's Anastasia. So I've done over the years a few of these IATs with no real preference noted in many of them. So what Fatima experienced with women in science, I didn't have that implicit bias, but I did the disability one for the first time yesterday, and I favor physically abled persons over disabled persons, which was a little bit disturbing to me. And reflecting on it, I realized that I associate some of the stock images, I think, with some terrible injuries I've seen over the years and general badness, traumatic amputations, and things like that. Because I certainly have physically disabled folks within my own family that I care deeply about and advocate for. So it was a disturbing bias to recognize in myself.
So thank you. And, you know, and that's why it needs to be in a safe space that you feel comfortable sharing. You're not going to be here judging one another, right? But I think it takes power of reflection to think about it and say, wow, that's not me, right? And all too often, the person we see in the mirror is a different one at times, right, than our actions. And that's what really today is about. It's really taking and moving forward. I think they're putting another mic here for us so that way we can hear the audience. It's just to have an opportunity to bring those unconscious bias to a level of awareness. So that way, when you're making decisions and high stakes decisions, right, whether they're in the patient care environment, but in this particular one, what particularly the chair wanted to kick off, as you're trying to recruit, right, your next workforce, right, as we make faculty selections, and really a new imperative is as we make resident and fellow selections, right, that we really do it, right, with our best evidence, right? As opposed to those things that have influenced our lives and our experiences that may get in the way of making the decision as to who are the best candidates. So the other, before we kick this off, I just wanted, and I know that those of you who are not here, you won't see the activity, but this is something that we developed with my colleagues that are here, those of you who may know her, Dr. Dalla Piazza and Dr. Ayala and Dr. Hill. You know, it's a very diverse team, but just wanted for those of you, and they have a sheet that they answered, and it's anonymous, so that when you stand up, because this will be a physical activity, you won't be representing yourself, but the person who filled this out. Have you heard disparaging or discriminatory comments about any of the following groups? And I'm going to try to go through this, some of it, but not probably all of it. Women. So if you can please stand if it's checked off. Okay, so look at the room. Okay, the next one, racial and ethnic minorities. Lesbian, gay, bisexual. So we could see, for those of you who can't appreciate the view, you can see that there's still, for every activity, people are standing. Transgender. Religious group. Immigrants or non-English speakers. So here we have, right, quite a few standing. And anyone fill in other? Because that's where we are not as inclusive and we met. How frequently? Never. No one standing for never. Oh, we have one. Okay, rarely. Okay, so we have rarely. Occasionally. Okay, so for those, again, not seeing, occasionally begins to draw up more individuals, and frequently. Okay, so we have less in the frequently, and then we'll do just really a few more, and then how frequently have you observed unconscious bias or stereotyping play a role in influencing clinical and professional decisions in a negative way? Never. Rarely. Occasionally. All right, so we start again, right? Quite more often than we would imagine, and frequently. And again, we have colleagues occasionally and frequently. Against whom have you observed these behaviors? Patients? Right, and here we are, we're in a patient caring, patient facing, right? Administration? Nursing staff? Right, so they are we, but we do us versus them. trainees, right? So here we have, right, quite a few. Faculty, myself. So there is no one, right? When we see it towards others, it really is something that we have experienced ourselves, and other staff members. And I think on that one, because we do want to get ourselves started, you can see the power of taking that moment to reflect and really the commitment. And I will have to say, you know, some of the colleagues that have been here, they've been through activities that have allowed them to do a bit more of the science of bias, how we get to where we are, but then what is it that we can begin to do? And the intent here is that as the president himself, right, has really developed an infrastructure to say that they're going to be a diverse, equity focused, right, and inclusive university, then it continues to challenge us, right, through all the chancellor-led units is what is it that we want to do? And one of them is really how do we prepare and how do we attract a more inclusive workforce? And let's see if I can get this moving forward. Okay, so just very quickly, the activity was to recognize, right, some of our own biases. I will go over because it's good to have a commonality of language and terms. Some of the challenges, you know, benefits, and we'll hear from you as well. And then what could you do in the search processes? Oops, and I'm going in. And then we have, so again, you know. Yeah, okay. So just again, the learning is really your own reflection today to see what is it that you would want to make, right? Hopefully as an actionable step. But let's go over some of it, right? And I think these last 3 years, right, with the COVID inequities, the racial reckoning, we do see the ugly picture. And just predating, right, we were really experiencing, right, what we called the Me Too movement and women saying, you know, no more. You know, and then I just want to highlight some things that normally we don't, right, in the world of medicine may not as much focus, but it's impacted. And then how can your leaders build a culture of psychological safety? So just very quickly, what are these, right? What are unconscious bias? And this is, you know, from the Kerwin Institute, which we did invite and did have here for us that led a number of workshops at all levels, right? For the program directors and the coordinators, for the chairs of the departments, for administrators, you know, and for faculty. But just these are the things that, right, are outside of our awareness. But they do affect, right, how we behave, right, what we do with each other and our decision making. And they can be positive and negative. And I think that you've heard a lot about what does it mean to belong to a particular identity group and what may be ascribed in a more positive way. And what is the dark history of America in terms of, you know, if you belong to a racially identified group, and particularly my colleagues who are African American and Black, and what does it mean to live, right, those experiences and what we associate. And I think we've all had them in terms of, I know my mother who is, you know, came as a teenager. Puerto Rico is considered part of the U.S., although we did go through it, you know, when there were tragedies in Puerto Rico that people questioned it. But, you know, she speaks English with an accent. She worked in a factory, didn't have the immersion, but I witnessed time and time again that when people are speaking to her, they speak louder. It's almost like if I speak louder, somehow she's going to understand me. She has no difficulty in understanding. So you could see the range of experiences that people have, right, when they are put in a different space and being othered. And then again, racism, very important. We are doing this, so we have a structural racism competency in our curriculum. It's not by chance, it's by deliberate. It's part of our health equity and social justice expectation. And in doing so, it really is an imperative not only that we take our students through it, but who are the role models, mentors, and individuals that are really co-learning and unlearning what to do, right? It's us. And so therefore, I think it's imperative, you as our, residents who spend a lot of time with the students to really understand that, but we as faculty as well, but thinking about racism as a system, right? And then really thinking about, what is it, in that system, right, that really doesn't allow individuals, right, to really, we ascribe value, and therefore we do not allow individuals to really achieve their full potential. And Cameron Jones is a very, very prolific individual, and, I would urge all of you, I will say that our students we start with that within the first weeks of their education. So they do go on a journey with us. And at times what happens is that they don't, because they go on the journey of reflection, they do the IAT early, they're really building knowledge and experience, they will see those behaviors that we may not manifest at times. And this is this is from the National Equity Project. It just kind of calls attention, right? The complex interplay, right, between our implicit biases and structural racism and how rooted they are. And I'll be happy to share this, with Dan, but, it's because it's a very busy slide, but you can see the history, the policies, the practice when many of you had at least an opportunity, not religiously, for pause and saw some of the historical perspectives appear in many of the news stations. You can see everything what happened with redlining, right, with the access of education, how communities and scholars brought forth that the pools, I grew up in Hoboken, it wasn't the town that it is today, and I couldn't afford it, grew up in a building, but we had a local pool and park. And what happened as, not at my expense, as we started to say we're going to integrate neighborhoods, some of the resources that were supposed to be for all, they began to disappear. Right, and that is the dark side of America in terms of what we've done with our communities and therefore disenfranchised individuals as they continue to come in. And so then you can see this cycle of, what happens in the complex interplay. And all we're doing is to take and call attention to it, what has been our dominant narrative. And myself, even as a champion, are there things that we do in our everyday assessment, right, of a learner in our environment that is rooted more in the way we've done it, as opposed to being consciously aware of, do we have biases that we are perpetuating that we can intentionally undo? So DEI, this is something when I was the chair of the group on diversity and inclusion and being involved with the birth of that group, we defined it, what it was at the time, and it has still been stayed steadfast. The group has been together, I think we're almost, I don't know if we're quite 15 years, but really calling out, again, what is diversity? And we were challenged as we were building this definition to try to be as inclusive and not necessarily just perpetuate that it's only for one group. So you can see it. I myself are along in many of these identity particular groups for diversity, but it's a travesty if we do diversity and we don't develop the type of inclusive spaces for individuals where they can feel. And the most important in retention of individuals is really to establish a culture of belonging and a culture of respect, right, for one another. And if we can have that, then I think that at least we'll have the readiness of the formula for all of us to be successful. And then othering is something that we really have been really championing, and it's the strength of all of us, right? Our families we came to communities where we wanted to be with other people so we didn't feel so estranged, right? But then what happened through those experiences, we began to either you're in my group or you're in that other group. And what made us rich, which I'm very proud of wanting to be both, right? But is we have to make sure that we mitigate those differences of othering in individuals, right? And it is so pervasive, right? And I'm just as guilty at times as others, but, I pause and I catch myself, right? And so really it's our shared social construct, that we are experiencing. I think about it because I'm a commuter between here and Newark, right? And Ithaca, New York, once you start going through the states of, Pennsylvania, and having done sports with my sons and traveling in, I'm not as common in the majority. I'm a minority, but I'm in a sea of individuals, right, who have left different experiences that some of you have had, right? There are more rural populations, and how are they best informed about individuals, particularly of color? It's the media. And so that's the ill information. And so you can see how then it shapes what their reactions may be. And vice versa, right? Because we're not as well informed and do not always understand what is the plight to be, right? And poor, right? Poor white America, and how are those images displayed, and how are they particularly groomed? So I think that's what we've seen, in our democracy, and the challenges that are facing each other. Oops, and I'm trying to advance this. So one of the things, just to really, and I love this display and lived through it, here at my own beloved institution, is really, equality and people who champion it. We want to give everyone the same thing. Of course we do. But there are times, right? And I think you've all experienced it yourself. Equity is about giving you what you need to be successful. It doesn't mean, right, in this picture, appropriately so, you're not taking away anything, right, from that tallest individual who can really see everything, right? But you're giving differentially. And then really justice is, how could we get to the root causes? If we can get to one, then that way we remove the barriers so that everyone, right, has the opportunity to thrive. And so that's really the conversation. So what are the benefits and challenges? And I figure we'd talk surgery. And then I left it blank to see, and I think we have the mic, what do you feel as a group? What would be the benefits to you, and what are challenges in achieving what you might desire? Uh-oh. Let's see, I don't want to put anyone on the spot. I think the faculty are probably waiting. The residents are not going to talk now, but please, students, just feel free. What do you think for surgery itself? And I don't want to call on Dr. Kunek, but here we have Dr. Lanzo. Yes.
With surgery, all the problems are by the textbook and by the book, and it's great when the patients follow the clinical pattern that's in the textbook, but we also know that a lot of times it doesn't happen, and you have to have I'll say right brain thinking to sort of think outside the box. And so having that diversity of thought in the operating room with your patients, with certain even systemic problems, I think is important, because those are challenges that affect all clinicians. And if there was only one way to do it, then I think we'd all do it. But there's often not. So having that diversity of thought is important.
I saw some hands go up. I don't know, Mike.
We have a very diverse patient population, and I think it's important for our patients to see us looking like them. And so, to have a large minority population of patients and an all-white faculty, I think creates problems and leads to misunderstanding. And so having a diverse resident group and faculty, I think, helps us understand better the people we're taking care of.
So that's a challenge that you see for surgery itself, right? As we begin to try to attract more individuals, right? And really have them become successful. So that way a team that's more diverse in experiences and thought can come up, right, with better, right, more creative and innovative solutions.
In surgery, we also have to quickly connect with our patients often and gain their trust, and having a open understanding of people's different cultural beliefs or where they may be coming from helps you connect with them on a more personal level and get them more comfortable with what is about to happen to them, and really helps develop the patient provider relationship.
So there is something to be said when our patients challenge or the community say, do you really understand me? Have you walked in my shoes, right? I can hopefully seek to walk alongside you. At times I may have, right? Depending upon what the issue, but have I fully, and then what is it that we can do to close that gap? Any comments from this side of the room?
To piggyback what Dr. Shapiro and Dr. Gore said, um, those are sometimes the barriers to access of care and improving patient safety and improving the quality of care. So if the patients see themselves in us, they'd probably be less reserved to do their screening or follow up on things that are often lost to follow up.
So I don't think any, if not anything else, I will move. But I thought, again, right, unless we ask the question of one another, right, and that's what it is when the search process, which we'll get to, what the university would like of us is that people are not just appointed to a committee, and they are, but that they're actually involved, right, in shaping it, right, so that those voices will matter. And that way, as you make the deliberations, people feel safe in this election. Right, and so those are the important aspects if we want to be transformative. So again, here, right, brings in different perspectives and viewpoints, more creativity, innovation, and I know that Dr. Jones is into innovation, right, and new solutions. So diverse teams outperform, right? Homogeneous ones. Think about if you have the same people in the same room, right? No matter how expert, if they're only clustered in one direction, do we really get the same outcome? Probably yes, right? And then again, and this is well described by scholars that are outside of medicine, including mathematicians and the business has figured this out. How is it that they draw different markets in? And why is it that we don't seem to want to learn from those lessons and practice and doing? Just pilot it and see if it works and then modify it. So I just wanted to share something because, here we are at this crossroads of individuals saying, the affirmative action, the fears of, critical race theory and all these aspects. This is the data. This is where we are, right? There are about 200,000, right, faculty individuals. What does that look like if you divide them up by race, just alone by race, right? And if you look at it across the different ranks, so I happen to sit, right? And this is not broken down by gender, right? Not yet. But I sit in that sea of that 1,040 individuals, right? Hispanic. But because we're not considered a race, and that's the enigma, right? Because as someone who's Latina Hispanic, why couldn't I be considered one? And that's why we want to remind us that it's a social construct that puts people, then you get another 654. So you could argue multi-race, we're about, close to 1,700. That is it for the nation. And we have 4 medical schools in Puerto Rico. And you could say, well, not all of the faculty there are Hispanic. If we were to remove them, we begin to see low figures. And then as you go and look at, right, my African-American colleagues, I just call attention. Look how severely low. So I will say, at the medical school, I represent one of 2, and we're progressive, right? We say we value diversity actually no, 3, because a colleague just got promoted. So we have 3 Hispanic full professors. And when you get to African American professors, I grew up in this institution in a sea of having them, but they have retired and died out. So right now I'm going to actually think very consciously. I know we have the dean, right? But most of his colleagues that were full professors, they have retired out. And so I'll come to me to see if there's really any others that really exist. So think about it. And we value it, we care, we do a lot here, but we need to continue to absolutely do more. The great thing is because of the new guidelines, we do have more colleagues that are rapidly ascending. So they are in the associate. Actually, I take it back. There are 2 full professors. And I think everybody knows the other one, Dr. Eloy, who just yesterday became a distinguished professor. So he has really joined a pretty elite group across the university. And then here when we go into gender and breaking it up, right? And women have been part of, medical schools. This time for us in the history of the medical school, it's our first time that we've actually crossed over beyond the 50% mark this entering class. And we do have it as an identified group that we work on to make sure that we can attract women to our campus. We feel it's a responsibility and that it's good, but once you break it down further, right, then I myself go into 341, right? And then similarly, right, and that has been the call to action when we say the progression of Black men, right? The dean himself, he goes into 523. If we exclude again, thinking around, multiple races. And so just wanted to say, have we really achieved and, eliminated the equity gap? And this is the story for women. This was the latest report, so it is about 3 years old, right, at the time. 51%, right, applicants, 48% graduates, 46% residents, 41% faculty. But when you start looking in leadership roles, right, division chiefs, right, we start getting the drop off. Full professors, right? Senior associate deans, you do tend to see more, still women, but still you can see the gap. And then when you start crossing over into department chairs and deans. So that is really what our call to action being more holistic in what we do. So diversity, right, as this TED met, and this was part of the group on women in medicine and science toolkit, right? Diversity drives innovation, and when we limit who can contribute, we in turn limit the problems that we can solve. And I love this one. It's a really nice, quick, easy read. I bought it at an airport. I love those Harvard Business Review books. They make a lot of sense, and I'm saying, why didn't I write that? But it's a good story written, and I thought it was a really great thing. Institutional excellence engages all of us, right, in a meaningful way, fosters our well-being. And this was right before we've hit the height of the continued epidemic of worrying about us as being unwell. And it allows for limitless opportunities. And this one I am part of, I do co-chair a anti-racism medical education senior leaders task force, seeing what can we do across the nation's medical schools in our senior roles. And we just put this forth is that for some of us, right, the door is always open. For others, the door, right, sorry, we're closed. Why is it that as we looked and we prepared our first framework, why is it that we are not equally, right, if you took particularly, in the racial minorities, not represented in that same thing? If you did it for women, if you started to do it for minorities, how often do you see a program director, a division chief, right, a senior associate dean, right, for education, right? You can find us in as associate deans for student affairs. You can find in the DEI space. But what is it about us if we are tapped for all these other talents and skills and clinical expertise that do not allow us to intentionally be groomed? And it's our unconscious bias of how we help people and groom them unintentionally, right? Because they're, culturally, there may be nuances that if I'm less knowledgeable about, how to navigate the administrative realm, I may not seek that in terms of being desirous of moving to those senior roles. And so I will say for myself, I'm a serendipity person. I am in this role through one critical turning point, being invited to be chief president, and that kind of opened the door and the hard work, but I could have failed at many, many times along the way because I am that workaholic, and many have failed, and that's what we call the minority tax. Get tapped, and I've been on every committee, I think pretty much, and for different presidents as we became Rutgers, and their councils and et cetera. And then nationally, because I'm a minority, I'm a woman and I'm a champion, so I get tapped for it, but it wasn't always because they saw initially the talent. My very first meeting that I served on a committee here, the person was relieved. I said yes, and they said, wow, that's great because you're a minority and you're a woman. Let alone I was, director of our intensive care units. I was a former chief resident. Hopefully I had levels of accomplishment, but it was because those two they could check off the box. But I appreciated that the person was very honest, right? And that way I knew that's what they were inviting me, that maybe for the wrong reason, but the right reason, because then I began to learn how to have my voice in an appropriate way, right? And that's the challenge sometimes because people can accumulate frustrations that alter their reality. So I think this one is from the Institute for Healthcare Improvement. And it resonates with me. We often know what we need to do, but we don't usually take that and move it into action, right? So there's always that gap. So hopefully today, after this, you'll be inspired as you continue to do your processing. And this one is very different for all of us, right? But it's really important. If people are here and all of you are attending, and I know part of it is your kickoff grand rounds, but some of you really, hopefully, were interested in the topic. So we are here because we're unleashing a motivation. But if we can at least flatten the curve and co-develop it, right, with individuals who have been most affected, and really be in an authentic relationship, because there's still always a power differential, and we distribute it, we may come up with a better solution that we could enact, and then we move it into action and we continue the cycle, right? It's those, PT, the plan, do, right, study, act, and that patient care, patient quality, safety. So why not apply similar principles, but engage all of us? And I love this particular book also. It happens to be someone, again, Harvard Business Review, about psychological safety. Is how do we really build a space for when you're making and talking about these issues that the person feels safe in articulating their viewpoint. And if they do, and they feel valued and respected, they're able to accomplish more. And I love this depiction, very simply put. We want to be, right? We are always saying we're high, 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 right? That's medicine. So, right, high standards, we set the bar high. It's never been. And I remember in 96 bringing leaders. I was part of a cooperative agreement nationally and bringing New Jersey, different colleges and leaders, and then saying, I'm going to do these summer programs, but it's not about lowering the bar, right? It's about you keep that bar high, you continue to raise it, but then you prepare individuals, right, to perform at that level. So again, high standards, but building high psychological safety, right? And there are principles, and they give you this nice little cheat sheet of what it is that we as leaders need to do, and it's very humbling. I'm saying, I do some of these, but some of these I'm not as well, so I need to intentionally work on them. And so I would encourage you to really take advantage. It's a nice read, and it gives us how some major businesses that we were affected and failed, and how in medicine we had some really catastrophic patient safety issues because we didn't build safe spaces and people couldn't speak up to help intervene. Microaggressions, big thing now that we're focusing on, really important, and it's those common daily place interactions, whether we're intentional or unintentional, that really affect what we have historically labeled as marginalized groups. We did pre-COVID a group of women. We had 3 groups. And what was the takeaway? They did the gender science, we did microaggressions, we did activities, regardless of specialty, regardless of whether MD or PhD, right? Regardless of rank, what did they say? They said at the end of the day, we learned to live with it. Right, and to me, frankly, that's not who we want to represent. We don't want you to learn to live with it. We want to be able to really transform, right? And I say that because I know that many of you care, and we are transforming. So even though that is something that has come up, because these episodes, right, they have been in our personal and in our professional life, is to really interrupt those and learn how to do that. And so just really thinking about, right, it's pretty straightforward, right? And this one really comes from the faculty search process. So now I'm going to introduce, so that way when you say, have you had the training? You've had it. You don't need to go in and do the online one. But this is what Rutgers, right? Commitment to acknowledging and reducing bias, a plan for active recruitment of underrepresented groups, and discuss and agree, right, upon a process for recruitment. So really, everyone should really have some contribution, and what are the clear? So the clear criteria is what's going to help you know what it is and how you're going to evaluate. And then again, this whole ranking and labeling candidates, and then read the recommendation letters with an eye for bias, right? That's what we have descriptors, right, that we tend to use that are very genderized in many ways, and that really we have to take that into account of the bias of the writer unintentionally, but that it rises to the same comparable expert level, of those individuals. And these are just some common biases in the hiring process, right? Familiarity, going with what you know, right? Affinity, preference for being with, remember we talked about othering and belonging, you're being in the in group, right? The halo effect, the positive bias based on one quality, right? And then confirmation reinforces either positive or negative, And I do have colleagues, when they look at and they see the CV and a person has trained in X place, they're like, wow, I'm going to challenge that. Does it mean that everyone who trained in that place was the absolute, highest tier? They were fine, right? But it didn't mean, and suddenly that person gets escalated to the top of the pile. So just keep it in mind, as you're looking at what are the many biases we put into place. And then biases that influence advancement, and you can see, and thank you, Anastasia, for sharing, right, ability, right, disability, age, again, it's the elephant in the room, we all know it, race, ethnicity, and then obviously, gender. So these are things, but there are things that we can do very intentionally, to really help mitigate those, right? But the committee composition can, right, also foster that, right, as we have, and the way that we respond to what behaviors or comments that are made. This is another, and this is really well known, and I actually went through training not that long ago, because I sent people and I said, I want to sit with you, and everybody thought that their groups were getting a different case. They led us to believe it was the same case with a different name. And so it was amazing, and it's well proven, it's well described, in the literature, and we've known this for a while. If you put a particular name, then that will alter your decision in terms of selection. And particularly if you take what we say minoritized names, right? Suddenly, we have all these things that we read into a CV that is not there, because that's influence from our experiences, that then suddenly that candidate doesn't emerge per se. So I just wanted to call attention, and you may have different methods of how you may want to look at individuals. Again, here, this is something, again, I pulled it directly from portions of their training, reasonable accommodations, for interviews. They do have these guidelines for us to be thinking, more inclusively in terms of abilities. I know that in certain areas there's a must, right? But what is it that we can, consider and do? And then similarly, right? And the fact that it's called out around, religious needs, that means that attention is absolutely needed. And then this is the HERC, and they have it, and you can go and you have to register for it to get access to their template, but it gives you a rubric, a framework upon which you can consistently say, okay, if we agree on these things, we're all going to consistently look. And that's why on search committees, we really do appreciate the committee to work out in advance. What are the questions, right? And then who is going to take turns in asking becomes less relevant. And they give you just some very straightforward of do's and don'ts, right? What is permissible in terms of thinking around just even age and, and some of these other things that affect individuals, right? But, that you can just, look at, and just have available as you think. Some of it, I would argue that it's very common sense, but I think most frequently probably fall into the first category. And thinking, but it's funny how things change over time. I would not have thought myself, to say, hey, this is the date of the high school or your college graduate. I just had to one yesterday I met with, and we talked about, they saw, behind, in front of them, because I was sitting in my back when I graduated medical school. So it wasn't a big deal, but yeah, of course, we both said, we're in the same decades. Unfortunately or fortunately, there's something to be said for that. Again, right, some of these, I think the main, right, is the being careful and cognizant of the whole marital and family status, I must say, over the years. And having done this with my colleagues, that whole belief, I remember in one group of program directors, fellowship directors, they acknowledged that they had a bias and they had male preference because they were concerned about the disruption for pregnancy. And I appreciated that they indicated that. But I said, do you know that men do take parental leave as well? And that's become more common, right? It wasn't in my time. It wasn't for many decades. But when I was interim chair for emergency medicine, it was not uncommon that would happen. And so therefore, there goes that myth out the door. And we have to begin to do better. It's just that our systems have not been designed to have the breadth and depth of the type of caring that we need to exercise with one another. But again, that should not be something that, we would be hyper focusing on in terms of, who can do what work because, they are belonging to a specific gender or sexual orientation group. So search committee, right? Again, that's going back. They're very prescriptive. Just say you listed the finalists, who was interviewed, what were the strategies, and I think Dan, appreciated all those forms. It's a search form, and we have to answer all those questions. And when they ask about diversity in it, what they really are looking for is what are the diversity viewpoints of that candidate? So I think to Mike's point, right? You can have very powerful allyship, right? But we did one time turn down someone. We were ready to, actually, I think we may have issued the offer letter. Then there were some concerning comments that the individuals made. And so I did speak to the chair and I said, it's time to tell them, no, that this is not going to be negotiable, but refer to our patients as those people. And and the chair called immediately and was very concerned. I said, this is never going to be a person that will be a fit here. So we really do have to, as a result of, and they will be rolling out some additional requirements on applicants to really just kind of once they're coming for the interview, what is their diversity viewpoint? And that's where I think it's very powerful because you may uncover biases that you say, they're not the right person for us. They're exceptionally talented, but this is definitely, if they want to work somewhere, they could work somewhere else. And so I say that, with it in terms of our deliberate nature. And again, just really quick things of this National Equity Project. It just reminds us, and we do more, not perfect, of historical, contexts for our students, but think about this whole thing, right? How do our policies, right, create and reproduce inequitable outcomes? Then what happens is when it happens in an equitable outcome, it reinforces our bias and it justifies why the existing inequity. So it's this vicious cycle. And we must acknowledge that othering, exclusion, structural racism is so normalized that we don't see it all of the time. and that we all have it, but we all can be connected, and I have interviewed over the years applicants to the medical school who did belong to an identity group, but they saw themselves divorced from the group and saying, helping those people. So to me, that also was saying, uh-oh, this is not the right individual, right, for the care of in persons of all, right, all identities and colors and beliefs. And this is I love this statement, is, we all belong and can thrive. Any effort that we can do, right, to interrupt our bias and its impacts, we have to actually work on the structures that perpetuate them. And it may just be there and something that you just don't even have taken the time to see. Or maybe, hopefully, you'll look at it, and then it's through that will create the opportunities. And these are what the frameworks the students receive. So I'm happy to send you the cards we print, just because, in the moment, it's a very emotionally charged situation, right? And not everyone knows how to handle. But, we did develop the charge framework, and that one was for focusing on bias. The interrupt is really, what is some of the language that you can use to help a colleague reframe and think about, right, their bias. And then the one thing I want to emphasize in all of this is, don't judge the individual, judge the behavior, right? And then it's our goal to change the behavior, right? Because once you then have labeled them, then it becomes very difficult for them to get out of that perception, right, that they're a racist versus the behavior was a racist, right, and or a sexist comment, and therefore let's figure out. But these are nice reframing questions, really, I'm curious why you say that. And so there are terms that come with, little sentences there. That sounds a little bit different than, like some other confrontational comments that we can make in the moment because we're angered, by, and then knowing when and how to redirect and what's the best place, right? Because in a public setting, sometimes you have to do that. But all too often it's best handled in a more private, and then when to really align and the individual who was affected, asking them whether they want you to handle it or are they comfortable, and helping them be prepared to address what they experience, right? That's a very empowering, but there are going to be times that they're going to say, I prefer that you do it. But it's also important that they begin to acquire the comfort, and the bridge framework, this was actually Dr. Hill, he loves acronyms, in terms of how can we avoid, othering. And it's about being ourselves, being whole, being authentically engaged, imagining what it might be like to be in the other person's shoes, and really through listening and learning, helping to generate new thoughts and narratives that bring you closer to levels of understanding. And then this is the team, just want it intentional, and it continues to expand. And you could see we do start out normally what our positionality is. So that way people know, just like we say, no conflict of interest. Well, there is a position that has fueled our lens, right, and drives us. And that way you know where we're coming from, but it allows everybody to know that we are human and we're going to have those positionalities, but by listening, maybe we can continue to shape. And then this is what Rutgers, so make sure there is a tool that gives you exactly how you might want to frame the questions, how you may want to frame your evaluations. I know that you already have them because I have a whole bunch that I have to fill out. You've been busy, Dr. Jones, in bringing candidates through. But the main thing they want to hear from when those forms are that every member was authentically engaged in the search process, decision shaping of who gets invited, right? And therefore they feel satisfied. And then answering, what were the candidates' viewpoints, on diversity. And I want to just leave you with this. And I know this has been certainly true for me, and it may be for many of you privately or, You know, in every position I've been in, there have been naysayers who don't believe I'm qualified or who don't believe I can do the work. And I feel a special responsibility to prove them wrong. I think that has clearly been, you know, the case. I will say, one of the deans, he's deceased. He was the one who gave me a tremendous opportunity, but the way he gave me the opportunity was interesting. I was going to be the commuter between Newark and Ithaca. And so, and he knew it would be challenging. And I knew it would be challenging, you know, with 3 children and a very young one. They were all young, they were all under 4 and under. But he said, you know, you have to think about it. We're going to try this, you know. And I was interim associate dean for special programs. And he said to me, you know, just keep in mind your children will grow up. And you may not have, you know, the career. You know, so it's like if I tilted the balance the wrong way, right? I may end up being a satisfied, happy parent, but I may fail in my role that I was being charged. So of course I had to figure out how to be that super woman and really manage it all and really far exceed any expectations because I refused, because I had been in, and was in critical care. I refused to be defined by that the role was only limited to this. I'm going to be involved in that. And that's really how I eventually, as one looks, the trajectory of the competency development in many different portfolios. But he was being kind. He really meant, but at that time, you know, was, you know, really said, I'm going to take a risk, you know, in doing this. I already had my grants and everything, but I don't know if this will work out because you may not manage the priorities as needed. And so, but he, again, he gave me the opportunity, opened the door, I opened it wider. And, you know, and so here I am. And so I just want you to just think about it as I look at CVs in a different way. I pick up all those other activities that people have done and I ask. If it's there, it's good to ask. And that's where I really learn what people love to do besides what drives them on their expertise, but what else do they enjoy that maybe we could help them with as they do their roles here. And I think that's been a far stronger formula for success for those that really can feel that they can thrive. And I think that is it. And I just with James Baldwin, very powerful. We use it a lot. Not everything that is faced can be changed, but nothing can be changed until it's faced. So let's use an opportunity to look at ourselves and look at the department and look at each other across departments and seeing what we can do. And I think on that, I may have run over. I don't know. I think we're over time, so I'm guilty. I know we started a few minutes, but to my colleagues who are, I can't really see. You know, thank you.
Did you ever
Yeah.
go back to the dean and tell him he really wasn't supposed to be able to say that?
No, I think I didn't. I think, like I said, over the years, we learned how to really find our voice. You know, but yeah, it's been an interesting, challenging journey. My oldest, you know, also was a challenge. He was adopted and had to leave on the dime. And they were threatening that the new system of separating the critical care from being a regular floor attending couldn't start in January because I might take a few weeks off. And colleagues went to the chair at that time and says, you know, this is unfair. Why is she leaving? And I'm like, oh my goodness. But it was these nuances that really teach you, say, what the makeup of a person, how individuals. The good thing in that one, while that chair, everybody was afraid of them, they really said, you go. So they did do the right thing. So I will say it balances out over time. They are well-intentioned, because I will say that dean was very caring, well-intentioned, you know, and that was the redeeming quality. But today we will not allow those comments to prevail. And that's what all of you today represent, is what worked yesterday, what we did not so far in the past, we can't continue to do today and into the future, right? And we're struggling with that because we can't change that overnight. And that's what we need all of you to change. And our next generation of, you know, our future physicians, don't do as you see in some of us. right? Live with what you are really excited about doing, and then you shape it. But don't become us fully.
A couple
But
things.
thanks.
First, we have a small breakout session up on 506 for any students and learning.
It's giving breakfast.
So feel free to come up. We have a few bagels and things like that. Dean, thank you very much for kicking off our
you.
session today. And I think that the theme comes from a slide that Dr. Gore showed us that we probably all can do a little bit better.
And we can. But that's about academic medicine, right? That's why we're all here. So look at the positive. Anyone who knows me, I am that positive person. I am that glass half full. I will always figure out a way with you how to fill it up. If it's drying up, let's figure out what to do together. So even though I point out things, don't look at us that this is the way we are. We are uneven. But the good thing is that we care to do this, and that is the institution that I feel that we are all here for. And my colleagues who are there, right, in the front lines with the patients, you care to be here and make that difference. We just might need little pieces of refinement every now and then because we're human. So thank you.
Thank you, everybody.
That's it. I'll go up. I get to have a bagel.
Yes, none of that is.
But you should go up. I get to have a bagel.
You like and
And carne.
everything.